we're now recording. I'd like to go ahead and start our conversation this afternoon by introducing our panelists. With us today, we have Veronica Cope-Briscoe, who is Director of Care Management for Pediatric Associates, and Susan Randecker, RN, Clinical Informatics Specialist for Pediatric Associates. Also on the line with us is Evan Carter, Senior Director with Audacious Inquiry, which is the agency's partner on the event notification service. Thank you all for joining us this afternoon. So a good place to start would be for each of us to give a little background on our respective organizations. I'll go ahead and start and then ask Susan if you could share some information about Pediatric Associates, and Evan, if you could share some information about Audacious Inquiry, that would be great. So as I mentioned, I'm with the Agency for Healthcare Administration, which is the state Medicaid agency in Florida. The agency, or AHCA, also has the lead under the 2009 HITECH Act for implementing the statewide health information exchange infrastructure, which we refer to as the Florida HIE. AHCA provides governance for the HIE, convenes stakeholders, and works to align the activities of the HIE with other state and federal health policy objectives. ENS, which is our topic for this afternoon, is one of the services offered by the Florida HIE. Susan, could you tell us a little bit about Pediatric Associates?
Thanks, Aaron. So Pediatric Associates is one of the largest pediatric practices in the Southeast. We cover over 350,000 lives with offices in South Central and North Florida. We have over 250 providers, including pediatric specialists in cardiology, endocrinology, and we have hospitalists in several locations. And Medicaid is our primary line of business. We see 60% Medicaid and about 40% commercial. And
Great, thank you. And Evan, can you tell the audience about Audacious Inquiry?
Sure, thanks. Audacious Inquiry, otherwise known as AI, has been in the health IT and health information exchange space for a little over a decade now. We have three primary areas in which we focus, those being software development, strategy consulting, and managed services. We do health IT and HIE related work for just over 10 health information exchanges across the country right now. Do a lot of custom development for them that oftentimes ends up being a more standardized product line, which is exactly how we came into the ENS platform as well. So that we also do a lot of outreach consulting, policy consulting, clients like CMS, ONC, folks like that, as well as state Medicaid agencies outside of the realm of purely HIE deployment and operations. And then we do a lot of managed service work for hospitals and individual providers as well. So it gives us a perspective at the high level, medium, and grassroots level, really, as far as how HIE impacts all aspects of the provider and healthcare spectrum.
Fantastic, thank you both. So the agency's objective, really, in everything that we do is better healthcare for all Floridians. And so we're very excited to be partnered with Audacious Inquiry, with organizations like Pediatric Associates that are participating in ENS in pursuit of that objective. So our topic this afternoon is ENS, and Evan, since you're here with AI, could you go ahead and talk about the basics that everyone should know about the service?
Yeah, definitely. So ENS, the Event Notification Service, is encounter alerting is a phrase that's been pretty in vogue in the health IT HIE space as of late, and we like to think that this may have been the first stab at that. And as the name indicates, it's a means by which we can alert or notify subscribers, folks with a care management or treatment relationship with an individual, when that individual's had an encounter at an acute care facility. So what we do is we establish connectivity with those hospitals, with those acute care facilities, and we receive data from those hospitals in real time, and then we compare it to panels that we receive from our subscribers, and we determine if anybody in the data we're receiving from the hospitals is actually somebody that's subscribed to by one of our customers. And if that is the case, we then package that data up into a notification, and then we send it to the subscriber in any number of combinations of formats and frequencies based on what the subscriber would like to receive. So it was built in order to be extremely actionable, extremely easily deployed, because an ADT, an admission discharge transfer message, which is what the whole system is powered by, is something that every hospital sends. It's not something that folks are still trying to figure out how to deploy internally and wrap their heads around the standards of. So it's operating with existing data, doing so in a very easy, very manageable way that is highly impactful to users and subscribers who then receive that information and can follow up and ensure post-discharge follow-up care goes according to plan.
So you say highly impactful for the folks who are receiving the data, and that's providers, ACOs, it's health plans. Can you talk about what kind of data they're receiving? You mentioned ADTs. What data are subscribing organizations getting over ENS?
Yeah, that's a good question. So ADT, it stands for admission discharge transfer, and that's exactly what we're doing. We receive data when a patient is admitted to a hospital, otherwise, which could be an admission in an inpatient setting or a registration in an emergency department. We then also receive data when those patients are transferred, either within the walls of that hospital or to a different hospital or a different facility. And we also receive information on discharge. The discharges are the most consistent, the most prevalent, and that's understandable given that there's no real misinterpretation of a discharge. But those are the three predominant event types that we receive. We are currently receiving the types of data that then comes within those discharges. We get, of course, we get the demographics for the patient, name, date of birth, gender, address, and phone number. And we use, again, we use those. There's two purposes. We use it to identify the patient and match it to the subscribers, and I can get into detail on that a little bit later on. But then we also, it's the most up-to-date contact information that the person is giving the hospital, the data source, at that time of the encounter. So if you're a health plan, an ACO, something like that, and you haven't received updated contact information from your member, your beneficiary, in 6 months, we may be able to get you a new phone number, which, that was a completely unintended consequence of the service that we found folks were really appreciated, was that, touch rates on follow-up really increased after subscribing to ENS, because we can get the latest demographic information that somebody's providing at intake. And we try to get into, of course, more quasi-clinical data about the encounter itself. We'll tell you where, of course, where the event occurred, what time it occurred. Is this an inpatient or emergency event? What's your member or your patient's MRN number within that hospital? What's the episode ID, so that you can then retroactively link the admit to the discharge once you've received both notifications. We try to get patient complaints. We try to get admit sources, hospital services, diagnosis descriptions, diagnosis codes, the attending physician, the name of the attending physician, and then we also try to incorporate a death indicator as well, in case the member, the beneficiary patient expired during the time of the encounter. So that is kind of the universe of data that we're currently sending. There is more data within the ADT. There are more event types that constitute ADTs, some of which is valuable, some of which may be white noise, and we are kind of always sorting through that, looking to find more data that would be, additionally helpful, and find ways to incorporate that and get that in the hands of subscribers. But we started with a manageable data set that like you and I both said now, is actionable, that didn't require sorting through a lot of things that somebody may not feel is pertinent, and that can really get to the heart of allowing somebody to see a list of their patients that have had an encounter and get in touch with them really fast based on the severity of said encounters.
And that's been the objective, right? Is working with our partnered hospitals and with subscribing organizations like Pediatric Associates to get that data into the hands of physicians and the hands of practice administrators, where it can be used to improve patient care. And we've been working with the agency has been working with the team at Audacious Inquiry on ENS since, I believe, 2013, and we worked with you on some other health IT projects for a number of years prior to that. Our partnership with Pediatric Associates on this initiative started a little bit more recently. Pediatric Associates started receiving the hospital encounter alerts on their patients via ENS earlier this year. And Susan, can you talk about how your organization is using this information?
So we started receiving this information in the early part of the summer, and we've slowly been building with the health plans and adding new health plans to our ENS feed probably on a monthly basis now. The best part of this is that we're now receiving all this data in a standard format, which is making it really easy for our analytics team now to go ahead and process the data, and we are making timely connections with our patients. The program itself is then running into an automated outreach for the patients, and when we utilize the diagnosis codes off of these, we can then assign it to the appropriate care managers or care coordinators as needed on a much more facilitating it in a much more timely fashion. We're also analyzing the data for the ER usage. We've already identified several patients that within the past month have already been to the ED over 5 times. This is data that if we were waiting on would be quite a while before we would actually realize that this is how many times that patient has been there, and we've already reached out and started educating the patient. We really like that when the ICDs are attached, or at least some kind of chief complaint, this is also helping us to automate and to reach out to these patients to discuss the diagnosis and their reasoning for going to the ED instead of coming to our facility. We've actually now started taking the data. We're getting enough that we can start to look at our overall concept, and using that timestamp that is, we find very important on that feed, we were able to we're starting to look at basically which offices we had. Was this patient able to make an appointment at that time, and starting to identify access to care? And if there was an office available, reaching out to discuss with the patient and find out why it was that they decided to go to the emergency room instead of coming into one of our offices. We've actually, with the first pass of this data, already started to identify. We have a very large percentage of the population that's utilizing the emergency room over the offices, and a very large percentage of that is for visits that should never have gone to the emergency room, such as pink eye and ear infections, and stuff that could very easily been treated at the office. So ultimately, this will help our utilization. We are also using this data for our patients that are being admitted to hospitals that we have hospitalists assigned to, so that we can try to continue that continuity of care and keep that patient within the Pediatric Associates family. And by utilizing that, our hospitalists have immediate communication with our care coordination team. So on discharge, that patient's going to get the best care available. And we are using that to send daily notifications to our providers to let them know when one of their patients has been admitted, or to either the ED or an inpatient setting, and to alert them of discharges. And then last but not least, we're using this as part of our population health care coordination.
So you mentioned patients with pink eye or patients with other non-emergency conditions who are going to the ER for treatment. We know that it's a big problem nationwide. In Florida, I believe the number is about half of everyone who receives care in an emergency setting could have appropriately received care in a primary care setting. So in your interactions with these patients, is there a particular reason that they're going to the ED? Is it just a matter of patient education, or what's shaping that?
We've just started this initiative to try to figure out if there is something that we can do to help facilitate them coming to the offices over that. Some of them is just simply access to care. The hospital is closer than the office. But as we get more data, we're hoping to be able to share that and see if we can come to a conclusion and hopefully a fix to try to help this issue.
Right, because it's a lot more expensive for patients to receive care in an emergency setting, and they're not being seen by their primary, who's going to know them better and know more about their background and their clinical history. So that's really interesting, and that's a good set of use cases that you've outlined there. So from the patient's perspective, you could talk about a patient who was a pediatric associates patient maybe last year, and continues to be a patient this year. How have things changed from the patient perspective? So what does this look like with the opportunity to do the automated outreach for follow-up, or to work with them, the individuals who are going to the ED for non-emergency care? How is the patient experience changing with the availability of this data?
Well, I'd say from the patient's point of view, this just looks like good medical management. We're timely in our interventions and our follow-up because we have the immediate knowledge about our patients' medical needs and location. Pediatric associates, we're accredited in a network and as a medical home. And that's real important, basically, in our mission with our patients. There's more support for the patient and family based on timelier outreach. Providers have direct knowledge about the patient's medical experience, not just based on what the patient is reporting. The coordination of care is greatly improved. It gives the perception, and rightfully so, that their medical team knows and cares about their health. It should instill confidence in their primary care provider. We strongly believe in our practice as a patient's medical home, and this assists us in being such a practice.
Right, and we've all, I think, kind of been in that situation where you're in the room and a doctor or a nurse comes in and they ask you a couple questions, and then they step out and someone else comes in and asks you all the same questions, or asks you things that are maybe available in a different practice, or that they would perhaps know about if they had access to this kind of data, that you'd been in the emergency room last week for something related to this. Right, from the patient perspective, it just looks like everyone's in the know and is better informed, and I would imagine that would inspire a lot of confidence on the patient's end, which is always a positive thing. So I want to go back a little bit. Susan, you talked about the automated outreach for follow-up, and then you do a little more hand-holding perhaps for those with chronic conditions. I was interested in hearing a little bit more about that. Can you talk about that a little bit more?
Well, this is Veronica. I'll kind of speak to that. A prime example of patients that are using the emergency room is our asthma patients. Asthma is our #1 chronic condition for our population, and the timely identification of these patients seen in the emergency room with this diagnosis assures that my care management team has immediate intervention. Many times we're contacting the patients the same day of their ER encounter and scheduling an ER follow-up appointment right on that day. I also have asthma educators that meet with the patient at the office following this appointment to provide face-to-face asthma education. This education, which is so crucial with these asthma patients, includes an in-depth review of their medications and review of their asthma action plan. Our goal is to have more stable patients that don't need to utilize the emergency room. These patients then have tools to identify their asthma triggers, utilize their medications appropriately based on their symptoms. And hopefully we're actually planning to do a study in the area based on asthma education, ER usage, and these asthma educators working for these patients. So we're bringing that quality component very much into the process. Would you like me to go on? I can speak about patients requiring an inpatient admission. My care management team has timely notification of their admissions. We have the ability to communicate with the hospital to begin addressing their needs immediately and anticipate what their discharge requirements are. We have we timely know of their hospital discharge. We're not waiting for someone to, kind of call us or send us a discharge report or something like that. It's more timely. It makes the transition of care from inpatient to home smoother, where necessary supplies and services are in place without any mishaps. The post-hospital provider visit is scheduled timely, and there's an assurance that the visit occurs timely. Referrals to specialists, necessary equipment, therapy, home health services, were all done timely. And this is extremely important because we have a great population of medically complex children. Again, when I go to the timely data also facilitates our identification of patients that are teetering on the edge of being less well. These are patients that have risk scores that are rising. With population health, you hear a lot about risk scores. If we have a patient that's frequently utilizing the emergency room, but we as a PCP aren't aware of it, we can't intervene timely. These are patients that require the medical home intervention, including assessment, medical management, labs, education, whatever it takes to bring their medical condition under control so they don't end up so medically unstable that they require an inpatient admission. It's all about patient management.
Yeah, all of these activities are fantastic. I'm going to have to invite you back for another webinar. This is terrific to hear this level of detail. So I believe Susan mentioned earlier that you have about 300,000 patients. Is that right? 350,000?
We have over 350,000, yes.
So about how many, if you know offhand, are covered by ENS?
100, almost 140,000. I want to say, with, like I said, we keep growing every day. We started off with 50, and now we're about 150,000 covered, I would say, roughly by ENS, and hopefully soon to increase shortly.
Okay, yeah, that's great. So we're not quite to half, but it sounds like we're moving in that direction. So,
Aaron, but for us, that is half of our Medicaid population. So we are, for our Medicaid population, we are a little over half.
Oh, terrific, fantastic, right? Because you said the Medicaid was about 60% of your population.
Correct.
That's really fantastic. So it sounds like this is really well received. Is everyone else inside of Pediatric Associates that's provided? I know I didn't send this to you as a question I was going to ask, but is there this enthusiasm among the rest of the team at Pediatric Associates about the data, about its use cases?
Yes, most definitely. I kind of feel like if you give a mouse a cookie, we started off with our data and it's getting more and more robust, and the trends that we were starting to see and the information that our analytics team is starting to be able to provide has just exploded, and the requests keep getting more and more in depth. So it's really been a really great experience so far.
Fantastic, fantastic. Well, thank you for the kind of provider perspective on receiving the data and what can be done with the data. I want to revisit the quality of the data in a few minutes here, but I'm going to turn to Evan for a minute and talk a little bit about how the data gets from the hospitals to Pediatric Associates and other subscribing organizations. So how do we know that Aaron Parsons, who received treatment at a local hospital, is the same Aaron Parsons who is a patient at Pediatric Associates?
Yeah, that's it's pretty important. That patient matching is really the most fundamental, foundational aspect of all this. It's what makes everything go, and you know, it's our secret sauce. It's a key differentiator as far as we're concerned. What I'm going to start by doing is telling you what we don't do. You may see there are other notification platforms that exist in this space that rely on what's called patient attribution. We do not. But what happens in patient attributions is that the system, the notification service, would be reliant on, you know, Aaron Parsons walking into the emergency room at a hospital and saying, "My name's Aaron Parsons. My doctor is Dr. Smith with Pediatric Associates, and my health plan is, you know, Sunshine, and then the system would then route directly to Sunshine, directly to Dr. Smith at Pediatric Associates. But we all know it's not always that nice and neat. There are numerous points of failure with that model in that, number one, you could be incapacitated as a patient.
Oh, Evan, we lost you. Did you go on mute there? Evan? Oh, well, I think we lost Evan. Susan, do we still have Susan and Ronnie on the phone?
We're still here, yes.
Okay, great. Well, we'll work with getting Evan patched back in here. I'm not quite sure what happened to the line. So he was going to talk a little bit about, or was answering the question about how we're getting the data from our partnered hospitals to subscribing organizations like Pediatric Associates. And as a subscribing organization, a participant that is receiving the data on your patients, it would be helpful, we've been talking about how useful the data is and it's actionable, but it's also important to talk about improvements that we can make. And so I wanted to ask, and be kind to us since we have an audience, but I wanted to ask about what you see as the most important improvements that can be made to a service like ENS. What additional data or what additional could be done? You mentioned the cookie earlier with your analytics team. What additional data would be of use to your team at Pediatric Associates?
First, we would love more of the hospitals to actually be sending the diagnosis and the chief complaint. It's great getting that demographic data and getting the most up-to-date data on our patients, but at the same time, then it takes a little bit of extra work to try to figure out exactly why that patient was there and if it was truly warranted. So that would be wonderful, and we look forward to seeing more of the hospitals sending that information. And I think the other piece that we would love is a place of service would be really great, so we can identify the ops patients and the inpatient surgery and outpatient surgery from the other admissions, so that we can make sure that when we send a patient, we know that they were supposed to be, come for a surgery, that now we can actually identify that day that they showed up and the surgery was completed and the patient was discharged successfully. And even taking that to another level, if we see where a 23-hour stay is what should have happened and now all of a sudden our patient has been switched to an inpatient status, our providers could follow up to make sure that everything's all right with that patient. So those would be wonderful things. And I think a length of stay on a discharge would probably be wonderful for those inpatients. And one thing that our analytics team did ask, because I asked them what would make everything wonderful, is right now we currently go off the policy number. It's kind of how the feeds are sent and I guess received by us. And they were wondering if there would be a possibility of adding the actual Medicaid number, because we have different plans that assign their own unique identifiers. But for us, the Medicaid number kind of is the identifier that kind of runs across all of our patients. So currently we have to do a little bit of legwork to bounce back and forth. And if that Medicaid number was included in that file, that would be a great asset.
So that's really good feedback. Let me ask you about the last one that you mentioned there, that the policy number. So you're saying the policy number is that the plan has, that the Medicaid plan is using for their panel for ENS isn't necessarily the same as the patient's Medicaid number.
Correct. There are several health plans that assign their own unique identifier, and when we're receiving it back, that's what's actually in that field, not the actual Medicaid number.
Okay.
So if we haven't seen that patient under that health plan, it makes it a little bit more difficult to make sure that we are matching that to the correct patient in our EHR.
So I think in terms of the improvements, and these are all useful things that would be helpful to the providers that receive this data and use it to improve patient care. I think that the suggestions for improvements kind of fall into two categories. And one category is those improvements that can be made by working with our hospital data sources, our hospital partners that provide this data. So you mentioned the diagnosis code or the chief complaint. that the patient presented with. We pass along everything that we receive, but those aren't populated consistently by every hospital that's currently participating. And so we are working, we've heard that concern expressed by other subscribers and that suggestion for improvement. We're working with our hospital partners on that and should have something to roll out on that topic fairly soon. I don't want to spoil the surprise, but we're working on kind of standardizing and improving those additional data elements that we know are so useful for participants. So that's kind of one category, is improvements we can make working with our data sources. Another category, I think that you mentioned the Medicaid number, that falls into another category where we can work with the subscribed health plan or with the subscribing organization. They can add that into their patient panel. And if it's included in the patient panel, we can route it back to Pediatric Associates as the recipient of the data. We can route it back to you as part of that alert if we have it up front from the health plan. So that's something that perhaps offline we can talk about how to coordinate that and make some of those improvements. But these are all actually really good suggestions and things that we're looking at moving forward on a couple of them in the near future. So that's good feedback. I want to circle back. Evan, have you been able to join us? Are you back on the line? Okay, it doesn't look like Evan has been able to rejoin us. But that's okay. So Evan was talking a little bit about the matching process and how being able to identify the patients on the basis of demographic information instead of relying on the patient in a stressful situation who may or may not be conscious or may not have someone with them who can speak for them and identify the patient and name, date of birth, who their physician is, who their payer is. That's not always possible, especially in an emergency setting. And so I know that the way that this is approached by AI and by ENS is by looking at patient demographics. So rather than relying on the patient to report their physician, to report their health plan, their ACO, the pediatric practice that their child is receiving care at, ENS looks at patient demographics. So it looks at the patient's first and last name, their date of birth, their gender, other characteristics, their different elements of their address, and it looks at those and weights those to determine whether or not that's the same patient that a health plan or a provider organization has subscribed to receive alerts on. And so it's a process of looking at the demographics for matching rather than relying on self-attribution. And there's been a number of studies on exactly that topic, on how do we successfully and consistently and reliably identify patients and have a certainty, a high degree of certainty, that we're talking about the same patient across a variety of settings. And I think that's something that's been accomplished with this demographic approach, and something that's borne out in the studies that look at this particular topic. So I have a message here. Evan, have you been able to rejoin the call?
Yeah, sorry about that. I have no idea what happened.
Well, that's great. I'm glad you're back on. So I was talking a little bit about the demographic versus self-attribution approach, filling in a little bit there from my limited knowledge base about that. I don't know where you picked up back into the conversation, but so we were talking about the matching process. So to put that question back to you again, if you could describe for our audience a little bit what that process looks like.
Yeah, could you tell me where I dropped off? Because I think I gave the longest and most detailed explanation of our matching process that I've ever given, and I have no idea how much heard it.
You were talking into the void. So you dropped off after, or right at the end, I think, of the self-attribution and the limitations of that approach. And I elaborated on that a little bit. So then we can rule out self-attribution as a great way of doing this and just talk about the approach that is in place right now.
Yeah, so the opposite approach to self-attribution is to have subscriber-based attribution, which is what we do. As we mentioned previously, we we need all subscribers to submit basically a big spreadsheet of all the patients they want to subscribe to, the demographics for that patient, and then we load that into our master patient index, and we compare that to the data coming in from all of our hospitals, all of which contains those same demographic fields. So we can do what's called probabilistic matching and score a given ADT against the individuals in the master patient index and determine whether there's a match or not. And it is incredibly complex and detailed. The process by which the master patient index evaluates two identities to determine whether they're a match. Every individual piece of data gets analyzed against each other, from the zip code to the gender to the date of birth. There are nothing needs to be deterministic. Nothing needs to match perfectly. There are partial scores available. For example, you can get a partial score on a name if it's phonetically similarly spelled. If there's a one letter off misspelling, it'll take that into account. Mike versus Michael, it's got the MPI keeps a list of aliases for commonly known shorthand names and whatnot. It also scores last names differently based on parts of the country where different ethnic groups may be more prevalent than others. It's really incredible the level of detail that the MPI software considers when it's assessing whether there's a match. And similarly, if a date of birth is 1 digit off versus being completely off, there's a different score that goes into play there. So it is literally looking at every letter and every digit of every demographic of all of the tens of thousands of ADTs we receive from our participating hospitals every day. And it's comparing each one of those up against the, what is over 4 million identities that are stored in the MPI right now that, encompass all of our subscribers. And so it's doing that, it's doing that comparison countless amounts of times per day. And it's an amazing platform that enables us to do that. And as a result, we are able to configure the algorithm such that we lean on the side of avoiding false positives. We have a zero tolerance for false positives. And what that means is that, every once in a while, we may not deliver a notification because the hospital was presented with data that was so drastically dissimilar than what the subscriber had given us that we were unable to make the match. But we would rather have that happen every once in a while than have the matching algorithm be too loose or too liberal to allow us to potentially suggest that there was an encounter that never occurred. That is the thing that we cannot allow. So that is the foundational principle by which we operate the MPI.
Right, and that's a great description. And I've been copied on some of the communications with subscribers. We, on rare occasion, will get a communication about a missed alert on a patient, and it's been great working not only with the subscriber but also with the hospital and with your team, and seeing the amount of diligence that goes into kind of hunting down the reason for that not coming across, and really being able to stand by the service and the platform and the process by which the data is matched and routed, and working to ensure that everyone understands that and has confidence in it. And it's been a good process. And I think that process and the larger kind of interaction with our stakeholders and with participants and the confidence that is built is responsible for some of the numbers that have been flashing on the screen and some of the numbers that we've talked about this afternoon a little bit, in terms of, we have 210 hospital participants covering about 94% of acute care hospital beds, 10 health plans, 23 ACOs, 4 provider groups, together covering over 4 million Florida lives. And so this really has scaled up and is delivering a large amount of very actionable, very useful data that in the hands of very skilled people like Susan, like Ronnie, like their partners and their associates at Pediatric Associates is making a big difference. And so I think this has been really helpful in kind of shedding some light on this for all the folks who dialed in this afternoon to learn a little bit more about these efforts. So Evan, while you had dropped off, we talked a little bit about some of the improvements that the folks at Pediatric Associates would consider useful, the kind of improvement in terms of more data, more event types, having the Medicaid number, some of the additional data elements that they'd like to see in the feed. I think that's really useful feedback. I'd like to also talk about what the future of ENS looks like going forward. So we have this great platform. We have kind of, you mentioned before, as a start, we have a kind of a lightweight implementation in terms of being able to get this highly actionable but small amounts of data out into the hands of folks who can use it, and that's a great start. Where can things go from here for ENS in Florida?
It sounds cheesy, but the sky really is the limit. The ENS itself was born out of customer feedback and stakeholder feedback from us. The service itself is not something that we thought up as a company internally. It was by virtue of our engagement in the HIE up in Maryland that said, "You got all these ADTs. Let's get these in the hands of the people that need them in real time." And that's where we came up with the service. And every inch along the way, all the new features, all the new enhancements have been born out of stakeholder feedback. So that is truly what drives the service. And as I mentioned when I was giving the company overview, we've got upwards of 10 state HIEs now that we operate in where we have this service, and it's really fascinating to watch. You deploy an instance of ENS, but based on the stakeholders in that given state and the challenges within that state and the market demands, as you said, it can grow into a completely different entity than in another state with another different set of circumstances. But that's incredibly beneficial because it allows us to really do certain use cases in an incubator in Tennessee, for example, or Minnesota, and say, did that work? Did that achieve the end it was that was desired? Would that work? Would that resonate in Florida? And so we have the benefit of really being able to pilot different stakeholder-driven features and functionalities within our different deployments that other folks can then benefit from. So people aren't starting from scratch. And to that end, the future of ENS in Florida is very much, looking at things that are already going on elsewhere. So, which is great because that means I'm not taking a shot in the dark here. I'm telling you about things that have already worked elsewhere. In Maryland, for example, they route CCD documents in the same exact way that we do ADT messages. If a hospital if hospitals plural want to start submitting to the HIE larger, document types, larger messages, pieces of data, really anything that's structured, any structured message that contains patient demographics can be treated like an ADT, compared to the MPI and then routed through ENS to our subscribers. So we are doing that with CCD documents in some of our deployments. In a lot of our deployments, one of the things that is, it's especially unique about Florida is the fact that we do not aggregate any data. And if we were to make a change in that regard and we're allowed to aggregate more data centrally than just what is, kind of the bare minimum that resides in the MPI today, we could give folks, we could push out to folks more information on prior encounters. We could highlight the folks who've had, 5 or more encounters, like the team of Pediatric Associates mentioned. We could provide that list. We could provide some sort of a history on those patients in the context of the notifications, which is actually something we do with a service called Prompt, which is a user interface that we layer on top of ENS that some folks may be familiar of. That's another thing we're looking to build out more so in the future. But when you talk about, just to go back to that, aggregation of data for a moment, we could do very lightweight value add from aggregation to say,
okay, this is this person's 4th encounter in the past 6 months, or, you know, this person has had 3 encounters pertaining to COPD or something like that. But what we can also do is full-blown public health analytics with ADTs. We have a function, a service that we call simply ADT Analytics, and what it allows you to do is truly jaw-dropping just by aggregating these ADTs. That can allow for GIS hot spotting, so subscribers can see where their heaviest utilizers actually reside. Can we go put a mobile clinic out on this street corner because these are the folks that are having the most unnecessary ED encounters? We can do LACE scores, we can do risk scores, we can group encounters by DRG codes and group them by hospital so folks can see what hospitals are having the most readmits and which ones aren't. I mean, the possibilities are absolutely endless. And that's something that, you know, that we're building out elsewhere and learning from elsewhere as we speak, so that, again, Florida could be the beneficiary of a very polished enhancement there if that was the direction we wanted to go. Other things we can do include, interstate data exchange. That is, this is completely vendor agnostic, but it is very simple to say, let's say we started talking with Alabama and Georgia and said, hey, if they had their HIEs, and we said, hey, if we ever see an ADT come in from a Florida hospital where the patient said their address is in Georgia or Alabama, if we literally just see a state code that says AL or GA, we're going to send you a copy of the notification. And you guys do the same for us if you see an address that says FL on it. And that works for neighboring states. It also works for snowbird states as well. And then all of a sudden we're trading ADTs. Then all of a sudden you can receive notifications. We could be doing this all across the country. And that is technologically so easy. The tricky part there is more policy or policies around interstate data sharing that remains to, we're still flushing out a little bit. But that is incredibly feasible and obviously very powerful stuff. We want to get the data in the hands of more people too. There are public health use cases here. Some things we're doing in other states are around overdose notifications. There's a obvious, if you think about it and connect the dots, there's a big play here with the opioid crisis. We're also doing newborn screening use cases in certain states where we are, by virtue of this service, we can effectively eliminate the need for hospital labor and delivery departments to manually report all childbirths within the state. So you really, like I said, we hear new use cases every day, and it's really there are countless opportunities to leverage this data and do very powerful things that are very impactful, but amazingly simple at the same time, and that's the beauty of it. So we are. I know we are, and you're certainly aware, others may not be. We're formalizing what we think that we're working on formalizing collaboratively what we think that roadmap's going to look like for Florida here in the very near future, and it's something that we'll be really excited to share with the community of ENS users and prospective users and participants here in the very near future.
Well, that's a fantastic overview of the variety of paths down which are available to Florida going forward. And like you mentioned, I think that's going to be a very stakeholder-driven process. But that's a conversation that we're looking forward to having. I think we had pretty good turnout on the call this afternoon, a variety of folks from a number of different organizations that would be very interested in some of these topics, and also in some of the use cases that Ronnie went through and that Susan went through before and elaborated on. I think all of this is very useful information for other state agencies, for health plans, for the health systems, for their provider organizations that have dialed in this afternoon to hear about this. So thank you to all three of you for speaking in detail and speaking so clearly about the opportunities that are available right now and available going forward. So we have a few minutes left, and I did want to go ahead and take a few minutes to basically to have us all be available to answer questions from the folks who are currently dialed in. If you are dialed in on the call, we had a couple of slides in the beginning that explained how to interact with the panel and how to ask questions. So you need to have your hand raised. There's a little hand button that you would need to press in order to raise your hand to be unmuted. We couldn't unmute everyone because it would be just audio chaos. But if you have a question, go ahead and raise your hand, or you have the option of sending it to us via chat. It looks like most people are dialed in on computers, so I imagine we'll get a lot of our questions by chat. And we do have a couple in the queue already. We have a question from Carlos who asks about what does ACA do to ensure that hospitals provide correct and valid information? I think that's a really good question. The information, Evan, my understanding is that the information is coming directly from the hospital system. So they have their own incentives to make sure that this information is entered accurately and that it's valid. And they're essentially just copying us on information that they're already entering and using for other purposes. Is that right?
Yeah, that's absolutely right. And, you know, there are a number of reasons for that. But yeah, you know, number one, it's their data that, you know, exactly. We want to copy verbatim because, as you said, it's the hospital's data. They have every reason to keep it accurate, you know, from quality of care to billing, you name it. And we also don't want to be in the business of manipulating data in any way, shape, or form. That is not our role. It is not our intention. We are but a conduit of hospital data. We do not want to you know, manipulate it or touch it in any way, shape, or form. So it is a pass through, and sometimes that's frustrating because sometimes we know there could be a, you know, an intricacy with a given hospital's data that we'd love to be able to fix ourselves, but we can't. And so, you know, we've got there is, as you mentioned, kind of that dance back and forth with the hospital data sources themselves to work on, you know, working out little tweaks in the data they're sending us, just because something may be, you know, coming across a little differently than we're used to. But as you mentioned, you've been party to a lot of those. You know, they've all been really fantastic partners and really easy to work with. So that's kind of the, you know, the high level overview on data integrity, so to speak.
Right. No, I can't say enough positive, and I'm sure you feel the same about the hospitals that are partnered with us on this initiative, and just their willingness to work with us. And actually, that goes the same on the subscriber side as well. Pediatric Associates, the health plans that we work with, everyone's been really very fantastic. It's great working on a project where there's that approach among everybody who is working together. We have a question, and it's a good question. It's a hard question from Clint, who asks about whether we have any hard numbers about how ENS has reduced avoidable emergency department admissions or other quantifiable improvements. I think it's difficult. I'll speak from the ACA perspective. It's difficult to really kind of baseline you know, what is the counterfactual in a universe where ENS doesn't exist or where we didn't implement this service and we don't have this data going out. I think it's something that we've talked about working with our partnered health plans. Certainly they have the underlying numbers and the analytic power to demonstrate some of these things. The state doesn't have the data necessary to really demonstrate that. I'm sure the vendor, because they're not holding any of the data, they're prevented by the agreement from holding on to the data. They can't do the analytics on that either to demonstrate that. We do have Pediatric Associates on the line. I don't know if Susan or Ronnie, perhaps it's too early since you just started. You mentioned earlier that you started over the summer, but has there been any effort or is there a plan down the road to quantify the impact that having access to this data is having? I know it's a hard question, but has there been any conversations around that?
Oh yes, most definitely. We are looking as part of the beginning of that process is starting to evaluate our data. Ronnie's looking forward to being able to do some case studies and I don't know if you want to speak a little more to that and utilizing this data for those points to help.
We definitely, and we're looking to see if our interventions decrease ER utilization. And the only way we're going to be able to, to do that is time's going to tell. We get the data timely and our interventions, and then we'll be able to measure it.
Well, it's a great question from Clint. Thank you for the question, Clint. And it's a tough nut to crack, right? It's hard to get at that without the underlying data, and that's exactly it. So it's going to take both data and time to demonstrate the impact that it's having. But we've had such enthusiasm among providers, among Medicare ACOs, among health plans for this data, for access to this data. I think we absolutely have, in terms of testimonials, in terms of more qualitative case studies, there's some good evidence that's starting to be compiled. We don't have anything that really kind of quantifies it on a statewide level, and I think that's something that will come as adoption continues to spread, and as, again, the availability of the data and the passage of time to demonstrate the difference in the admission rate, in the readmission rate, for different chronic conditions. So we'll get there, but we're not there quite yet in terms of the available data. So we're about out of time. Any last thoughts, Susan or Ronnie, that you'd like to share?
No, but thank you for allowing us to participate.
Well, you were fantastic. Thank you so much for your time this afternoon and for talking about your experience and sharing that with the audience this afternoon. Evan, any last words?
No, thank you for having us on, and I echo what you said. Thank you, Susan and Ronnie, for partaking as well. It was really interesting to hear from you all. So thank you all very much.
Well, thank you to all of the panelists. Thank you to everyone who took the time this afternoon to dial in and learn a little bit more about this. If you have any questions, certainly feel free to reach out to me or to other individuals at the agency who are tied to this project. My name is on your screen right now. My email address is aaron.parsons@ahca.myflorida.com, or visit the Florida HIE website. It's florida-hie.net for more information. And again, if you'd like to speak with us offline, I'd certainly encourage you to reach out. So thanks again to the panelists and to everyone for dialing in, and enjoy the rest of your afternoon.
Thank you. Thank you.